So in order to talk about the future of well childcare in pediatrics, I actually want to start with a different question. Is well childcare meeting the needs of children in low-income communities? And I think this is really a critical question for the field of pediatrics. And that's because for children between the ages of 0 to 3, the pediatrician or another pediatric clinician is probably going to be, for many kids, the only professional that sees them before they enter school. So that means as pediatricians, we have about 10 tops, right, well-child encounters where we can really have the opportunity before the child enters school to identify and address an array of social, developmental, behavioral, and health issues that could really affect that child's life later down the road. And it's also an opportunity that we have to help teach parents the tools and strategies that they're going to need to help their child reach their full potential. However, these vulnerable children who are living in poverty really have a vast array of needs that impact their health and their well-being, and our delivery system for well child care might not quite be structured in a way to meet all these needs at one visit. So you're probably very familiar with kind of the landscape of children and their living in the United States, but I always like to go through these slides just as a reminder. 22% of US children live in poverty. Just 48% of children who are poor are actually ready for kindergarten when school starts. And 24% of children live in households that are food insecure. So this is what children come to their well visits with and what their families come with, these kind of issues. And there have been multiple studies, both done nationally, locally, that show that there are several deficiencies in the way that we provide well child care to children. So first, most children don't receive the recommended number of visits. But that's not really the issue, because even when they do receive the recommended number of visits, they don't actually receive the recommended care that's supposed to be a part of that visit. And so, in fact, about fewer than half of children will receive all of the preventive services that are recommended for a well visit. And so we could start with just thinking about anticipatory guidance. And if you've looked at Bright Futures, the range of topics for anticipatory guidance is huge and probably not feasible to complete in a 15-minute visit. But studies have shown, not surprisingly, that most parents have unmet needs in their anticipatory guidance as far as well child care visits are concerned. And so what this means is these are topics that they wanted to address, specific topics that they wanted to address at their visit, but they didn't have the opportunity to do so. And then there's psychosocial screening. The psychosocial screening, these are looking for family risk that can affect the child, things like homelessness, maternal depression, intimate partner violence at home, violence in the neighborhood, food insecurity, these types of issues that are important but really aren't addressed in well child visits. And studies have shown that these are the one part of well child care where pediatricians feel the least prepared to handle. And parents, studies have shown that they don't even really know this is supposed to be a part of their well child visit, so they're not going to come to the visit with these questions ready. And then lastly, for developmental and behavioral services, what we know is that first, when you ask parents what their biggest needs in well child care are, what they're missing the most, this is what they mention. Help with understanding the development of their child, knowing what to expect, dealing with toddler behavior, that kind of thing. And for instance, if you just look at how often kids get a developmental screen that's standardized, just 20% nationally will have a developmental screen. So this is also a big area of concern and a deficiency in our care. So when we do see a family at a 15-minute usual well-child visit, we have to ask ourselves, is that time, is this visit enough to meet the array of possible needs that that family might have? And if it's not, how do we change the visit structure or redesign the visit so that we can actually meet the family's needs? So many of you might be familiar with Donabedian. Avitas Donabedian was a physician and really a pioneer in the study of healthcare quality. And so he designed this, or developed rather, this model to explain the quality of care, that really it comes from structure, process, and outcomes of care. The structure of care is really the environment of that care occurs in, the physical facilities, the organizational elements like staffing and payment models on how we provide the care. And then there's the process. The processes of care, these are all the actions that we take with the patient to actually deliver the care. And then the outcomes, this is the effects that the care that we provide have on the patient, on their family, and their experiences of care, and on the health of the population as well. So today I'm going to really focus on the structure of care and really thinking about three main parts of the structure of care. So when we think about structure, the first thing that comes up is providers. So who are the providers of care? And the most, obviously they can be pediatricians, family docs, nurse practitioners, PAs, but there's also health educators, promotoras, lay health workers. There's a range of possibilities for folks who can provide at least some part of well child care. How is the care provided? That's the second element of structure that has really been studied in the literature. And those things are around the format of care. So being how that child and the family receives the care. So the typical format, of course, is a one-on-one, face-to-face visit. But in terms of one-on-one visits, there can be group visits, and that's when well child care happens with a group of parents that all need that same, say, 6-month visit. There's also non-face-to-face formats of care. You can use telehealth, e-visits that rely on text messaging or internet-based services. So there's definitely a range of formats of care that have been studied. And then the last one is, where is the care provided? That's the location of care. And that can be obviously in the clinical setting, but maybe in other places that are more convenient for families or provide a different context for the visit. So places like daycare centers or preschools when we're talking about the preschool-aged population. And as far as that provides a little bit of context and convenience, there's also community centers, mobile vans, different locations are available as well. Retail-based clinics is another one that has been discussed in the literature. So many of these alternative providers, formats, and locations of care have really been explored in the literature. And back in 2013, we wanted to see what the evidence for these were. What's the evidence for their effectiveness and efficiencies in well child care? So we conducted a systematic literature review through 2012, really looking at those questions. And we found 32 articles that addressed the major question about tools and strategies for well child care redesign. The focus was on children ages 5 and under 5. So the first element that had some evidence was around the question of who are the providers. So there's actually some pretty good evidence that shows that using non-physicians as developmental specialists, so these are nurses, RNs, social workers who are trained as a developmental specialist. So in essence, they're trained to provide enhanced developmental and behavioral services at well child care visits. So developmental surveillance and screening and counseling. And so there's good evidence that these types of developmental specialists can enhance parenting practices and can improve the receipt of well child care services. And the most kind of well-known of these is a program called Healthy Steps. And Healthy Steps has been studied across multiple practices across the nation to show these results. And there's about 17 publications that have published on this. So that's for providers. That's really the major conclusion we can make on the provider question from the systematic review. And then we can look at, well, what about the formats of care? So for formats, the format that really had some fairly good evidence was group visits. So group visits are kind of what they sound like. If you have, say, 6 to 8, let's say mothers who have a 6-month-old who all need that same visit, instead of seeing them separately and doing the anticipatory guidance over and over again, you do them all together. They have a chance to learn from each other and share experiences, and they mostly have more time. So the group visit typically is maybe an hour and a half because they all come into the same room, they get examined separately, but right in the room, and then they have maybe 45 minutes for a nice discussion around the anticipatory guidance, the psychosocial screening and development. So the studies that we have on group visits really show that in terms of parents receiving well child care services, it's equally effective as an individual well visit. You don't lose any of that, and potentially more efficient just because you're seeing more patients at a time, and the patients are getting more provider time. And then as far as non-face-to-face formats, the one that came up in the systematic review was really on using web-based tools. And so web-based tools, these range from internet-based tools or web-based tools that allow the parent either before the visit or after the visit to provide some pre-screening information to make that visit more focused on their needs, or to provide anticipatory guidance on specific topics that they can learn about on their own and get additional information after the visit or between visits. And so the evidence on that was not bad in that it showed that parents receive enhanced anticipatory guidance, so they report having more topics, more education. And there's also some evidence that those kinds of tools may reduce the number of clinical contacts that they make between visits. So calling the clinic or the practice between their well child care visits with additional questions if they have access to something that they know that their doctor has already recommended to look at. And so you might be wondering, well, what about locations? That was the third thing. I had the providers, the formats, and the locations. There really were only 2 studies that were helpful on the locations of care, so just not enough evidence to make any conclusions about that. So these are, we found some evidence in this review that there are some promising tools and strategies that can be used for well child care and could be ready for a larger scale testing. So what do we do first? Which of these would we study? Which of these would you have a practice or a clinic implement? And I like what Don Berwick said when asked, what's the one thing you would do to improve healthcare? And he said, do everything. So there's no reason to continue to tinker around the edges of healthcare or of specifically for us, well, child care, but really you can do multiple things at the same time to get the outcomes that you're looking for, and that might be necessary. So we took that to heart in this next study. I'm going to tell you about well child care practice redesign, and this is parent-focused well child care. And in this study, we partnered with community clinics around Los Angeles and practices to really look at improving the structure of well child care. So that project had 3 main phases that I want to talk to you about and walk you through this morning. The first was getting stakeholders' input. So you can imagine the stakeholders in well child care, pretty straightforward, would be parents and the families, would be the providers and payers. So those are the stakeholders that we focused on, and I'll tell you a little bit about that later. Then we took that input into phase 2 to really actually develop what the particular model could look like for the delivery of well child care, a new structure of care. And then in phase 3, we actually wanted to test it and get some data on what happened. So I told you the stakeholders that we wanted to examine were providers, parents, and payers. And we collected data on each of these stakeholders to find out what types of tools and strategies would be useful for them, what would be acceptable, and what they think would for them be useful in improving the well child care services that they receive or deliver. So there's two studies I want to talk about as far as the stakeholders' views. And they're both get a national look at the providers. So the first one we did back in 2006, and it was a national survey of pediatricians, really to get at their perspectives on what an ideal system of well child care might look like, given that it would improve effectiveness and efficiency being the two main outcomes. And basically what we found is that they thought that decreasing the reliance on the physician as a main provider of all the well child care services would be a good thing, and using non-face-to-face formats, particularly for anticipatory guidance, to boost that element of well child care were things that they were interested in. So just a couple years after that, another group looked at that same question, but looked at it across using qualitative data. So they did interviews rather than a survey data. And they focused their question a little bit differently on the developmental and behavioral services within well child care. But they found results that were fairly similar. So that the pediatric clinicians, and they looked at clinicians across multiple cities across the country. They were really interested in the organization of the visit, how that visit is structured. They thought that using things like group visits, non-face-to-face tools, web-based tools for improving the receipt of anticipatory guidance would also be useful. So very similar results on a national focus for pediatricians and pediatric clinicians generally. But Tip O'Neill says that all politics is local. And I think the same is true of the research we do, especially when it's focused on communities. So we decided to take a local look. So we started with parents and really assessed in focus groups, focused on low-income parents, what they thought about their current well child care and how it could be improved, and whether or not some of these tools and strategies we saw in the literature would be useful for them. And so what we found was that the two main elements they cited as challenges were not having really good access to their provider between visits. So if they had a question they wanted to ask, they pretty much had to make an appointment for a visit. And then the second one was inadequate behavioral and developmental services. And this was across the board. They just didn't feel like they had enough help dealing with behavior, normal behavior in children, and understanding development. But luckily, they supported some solutions to well child care structure, and they focused on using non-physician providers. They thought that they would be useful in helping them get more of the services, particularly around behavior that they needed. They were interested in using non-clinical locations to improve the context and the convenience of care for them. And then they also were interested in having multiple options available for how they receive their services. So some said, some months I might want to use an internet-based tool, and some months I would like to do some text messaging and get some health information via that way. So this next study was done at a similar time as the focus groups on low-income parents. And this was done by another group led by Marty Stein. And what they did was they looked at parents who were a little bit more, their group of parents was more educated and more middle class. And they asked them around this similar questions about well child care and how they would like to receive well child care. So some interesting similarities and differences that I think can be related to the socioeconomic background of the families. Similarities were that both emphasize a need for better behavioral and developmental services within the visits. And they wanted options for information exchange as the low-income parents did as well. The differences were really around two things. The first was group visits. So in that first study, the low-income parents, one of the formats that they really thought would be useful for them were group visits, because many of these families felt isolated and didn't have a lot of support, and they thought having their visits in a group would give them that kind of support. And they also wanted to learn from other parents and not just their doctor. But the group visits weren't really supported in this more middle class sample of families. And we can talk later about kind of why that might be. And then they also thought that pediatricians should do a better job of telling them why well visits are important anyway, which I thought was pretty interesting. So let's see, Vince Lombardi says you can accomplish anything if you're willing to pay the price. And I think that's probably true of well child care. We can, if we could provide concierge service to every family, we could probably get pretty good outcomes, but nobody's gonna pay for that. So the last stakeholder we haven't talked about yet were the payers. The payers are the health plans, the medical groups that take some risk, and then at the time of this study, the 2 state agencies that were administering Medicaid and Healthy Families. And so we interviewed their executives about this is what we found in Well Child Care Redesign, the perspectives of parents and providers, what's gonna be feasible from your perspective as a payer. And so what we found was, in general, they thought that increasing the reliance on non-physician providers to provide a lot of the, I'm gonna call talking parts of well child care, using some web-based tools to improve care would improve the efficiency and effectiveness of care. So they were on board with that and thought that that would be useful. But they did highlight some obstacles that plans and practices have. And the major obstacle was a lack of incentives to redesign care, a lack of incentive to really make things differently, to make things different. And some of these barriers, so the barriers went across payment systems, so whether we were talking about a capitated system or a fee-for-service, both were not incentivized to do that. And then some of the state level barriers that we got from the state agencies were really interesting. The first one's not surprising, that the Medicaid reimbursement rates are low, and that is probably a disincentive in putting a lot of effort into changing the way you do something that you don't really see a lot of financial gain from. And the second one, it was a little bit more surprising, HEDIS, which is basically about 90% of plans across the country use HEDIS as a quality measurement tool, and they report their HEDIS results. So it's an important thing for health plans. And when you look at the HEDIS measures for well child care, they're really simplistic. It basically looks at are you up to date on immunizations, and are you up to date on your well child care visits? And if you do those, that's really what well child care quality looks like on HEDIS. So there's not a lot of incentive to change what's inside of the visits, because you don't get credit for that on HEDIS. The other part of HEDIS that can serve as a disincentive is that to be up to date on the well child visits, you actually have to have an in-person visit. So let's say you have a pediatric practice and you decide for that 9-month visit, since there are no immunizations, you want to offer families an e-visit. They don't come in, they miss the 9-month because there's no in-person visit, and you get dinged on your HEDIS measures. So then the last stakeholder group that we focused on was, we went even more locally using a group of FQHCs in the Los Angeles area. And in this study, we examined the perspectives of really the entire staff and executive staff, providers at that clinic and the clinic sites. And what we found was very similar to the other stakeholder groups. They really thought a pre-visit tool would be useful to help customize a visit to the parent's needs. If you look at Bright Futures, it's overwhelming to think that you could provide all that stuff in one visit. So there's got to be some way to figure out what's most important to the parent and what's most needed for that family. They wanted a structured system to communicate with their families in a more structured way between visits. They thought a health educator would be useful in providing many of these, I'll go back to talking parts of the visit. So that's anticipatory guidance, psychosocial screening, developmental and behavioral services, everything but the physical exam. And then they thought that health educator could work well in a team-based model of care where the parent really has a team working for them. So that takes us through to the second phase. Phase 2 is really thinking about, well, what's the model going to look like? That's all just stakeholder input. So for the second phase, we focused on developing the model, and we used what we call Community Advisory Board. And what that is so we worked with 2 Medicaid-focused private practices in Los Angeles area, and then as a separate group, we worked with a group of clinics part of the same FQHC. And so each of these groups set up a community advisory board that included their pediatricians, included some of their executive administrative staff, and then parent representatives, medical assistants, and some front office staff. So people who are really providing the care and receiving the care. And they worked through a research process with an national expert panel, which I'm going to tell you about in a second. This is the publication that we published 2014 that really describes this whole long process that I'm going to fly through. So the first step of this process was the community advisory boards, call them CABs. And basically what they did is that they received all the information around the stakeholder input that I reviewed. They reviewed the systematic review, so they understood the evidence on these different tools and strategies. And then they took that information, and their job was to develop specific models of care that could be evaluated. So this is what they came up with. 4 models that are distinct and comprehensive for providing well child care services. The first is a group visit model, providing well child care in groups. The second one was a one-on-one team-based model, which I'll talk about more in a second, really focused on the health educator as providing most of the routine well child care services. The third one was a hybrid of the first 2, some group visits mixed with some one-on-ones. And then the fourth one was a technology-based model, which really took out a lot of the education and guidance and allowed parents to receive that outside of the visit. So once they figured out these 4 models, then they took it back to an expert panel that was created specifically for the project. It was a national expert panel on well child care redesign. We got nominations from the major pediatric organizations such as AAP. And they took their models and ranked them on the quality of care provided, receipt of recommended well child care services, feasibility and efficiency of the model, and then patient-centeredness of care. The CABs got those ratings back. They had a 1-day retreat. They thought about feasibility and acceptability. They did they looked at their cost analysis, and from that, they decided what they were going to study and what they were going to implement and study. So there are 2 different CABs, as I told you about. One was the FQHC, and they chose a group visit model. And the other one was the 2 private practices who focus about 90% Medicaid families, and they chose a one-on-one team-based model. So interestingly enough, the models were really similar. First, they both relied on a health educator to provide most of the anticipatory guidance, psychosocial screening, and the developmental and behavioral services. That point of that health educator doing those services was really to free up the pediatrician so that they could spend more time in visits with children with chronic diseases, complex needs, and more time seeing their acute care patients that are coming in. They, both of the models used a web-based tool so that they could use their time with the families more efficiently and customize a visit to their needs. And then they both included some kind of method for allowing patient communication between the visits. So I'm going to talk about the one-on-one team-based model, which the group decided to call PARENT, because everything needs an acronym. And this is Parent-Focused Redesign for Encounters, Newborns to Toddlers. And so the center of the intervention or of this design of well child care is really the health educator, which we decided to call a parent coach. And so the parent coach provides most of the routine well child care services. She uses a well visit planner, which is the web-based tool that customizes the visits to the parent's needs. This was a tool that was developed by Christy Bethel in Oregon at the time, and I'll talk about that in a minute. There's a text message service and, of course, a brief focused clinician encounter for the physical exam and to cover any clinical issues. So this is the parent coach with one of the clinics. This is the clinic actually in Duarte. Dr. Bruno is the lead for this clinic. And this is the parent coach in the clinic that's located in Compton. And Dr. Chavez is the lead for this clinic. So I want to walk you through the process of the parent coach visit. So parent comes in with their baby, and they get checked in at the front desk as usual. The MA brings them back, does the weight and measurement, and puts them in a room, and then the door closes. And that's a time that we all have been through ourselves as patients, where you're waiting for the physician to come and start the visit. And that's a time that the parent coach utilizes. So she goes into the room. She spends somewhere between 15 and 20 minutes going through anticipatory guidance. It's focused on what the parent already said they want to talk about, which I'll tell you how in a second. She does psychosocial screening with specific community referrals that she has cultivated over time, relationships with. And then she does developmental surveillance, developmental screening structured using the AAP schedule, and then some counseling and guidance on development and behavior as well. Then when she's done, she puts everything in the EHR, summarizes what she's talked about, using kind of a quick, the dot phrases that we can have, and highlight anything that the physician really needs to focus on that has maybe come up. She leaves the room, and the physician comes in, does a physical exam, addresses any of the clinical issues that are there, and might reinforce an item that the parent coach has highlighted. This is the Well Visit Planner. It's a web-based tool that the parents can use to customize their visit. They answer some questions on psychosocial risk, health risk, education and guidance things. And what they answer here gets uploaded into the EHR really instantaneously, so that when the parent coach sees them, they know what they want to talk about. For anticipatory guidance, the parents receive basically a list of the possible topics by that child's age that are in Bright Futures, and a little explanation. So there's a topic heading of the anticipatory guidance topic, and then under that they can see like a little phrase that describes what that is about in parent-friendly language. And then they can highlight, I want to talk about A, B, and C. So they choose 2 or 3 things of the long Bright Futures list that are most important to them. And so, as you can imagine, most of our families, over 90% Medicaid insured, don't have internet access at home, and this tool is really not an app, so they couldn't do it on their phone. So they really needed to have internet access on a computer. They don't have that at home, so we provided a kiosk for them to do it in the waiting room at each of the clinics. We also used an automated text message service. This is really to reinforce some of the anticipatory guidance topics so that parents could kind of be reminded of stuff between visits. And it was customized to the clinic and customized to that patient's age. So last thing I want to talk about today is the results of the randomized controlled trial that we did of this parent intervention. So this was across these 2 clinics. What we did is we randomized on the individual level. So it was a individually randomized trial. Any family coming for a well visit at either of the practices with a child 12 months or younger was eligible for enrollment. And then kids stayed in the study for a 12-month period, either receiving their well child care with this parent model or receiving the usual well child care. And then at 12 months, we used parent survey to assess outcomes. And the outcomes we looked at were really around well child care quality, so whether they receive the recommended preventive care services, whether what their patient experiences of care look like, or their parent experiences of care, and then some healthcare utilization measures as well. So we enrolled 251 parents through both of the clinics, and they were, of course, randomized to intervention and control. They stayed in the study, as I said, for 12 months, and then at 12 months, 90% completed the 12-month survey so we could analyze data. So what did the sample look like? Mostly Latino and Black. The average age at enrollment was 4.5 months. There was a low-income population, as you can see here, and low education as well. So when we compared the intervention versus control, and I'll also say that they were similar. There was really no differences when you look at their baseline characteristics. But when you compare intervention and control on the receipt of preventive care services, the intervention kids did better on each of the outcomes for preventive care services when compared to the control. So these are generally on a 0 to 100 scale. That's the range here, or that's the scale. And so for anticipatory guidance, you can see the intervention kids scored much higher than the control kids. And this composite variable for anticipatory guidance was about 18 items asking about each specific topic in the Bright Futures. Health information, they scored higher than the control. On psychosocial assessment, this is one of the widest gaps that we saw between intervention and control, where the intervention families had a score of 93 compared to a 71 for the control for family risk. For structured developmental screening, the intervention kids were more likely to receive a structured developmental screen by parent report, and they were more likely to say that their developmental and behavioral concerns about their child were actually addressed at the visit. So what about experiences of care, which are obviously important to families and to providers? The intervention families reported more family-centeredness of care. They reported more helpfulness of care. And on the overall rating, this is actually a CAPS measure, there was a slightly higher overall rating for the intervention versus control. So what about utilization? We looked at whether or not well visits were up to date. We looked at the number of urgent care visits. These first two items were chart review. And then the last one was parent report on the number of emergency department visits they had over the 12-month period. And so what we found were that they were pretty equal on having their well visits up to date and the number of urgent care visits that they made to their practice. But we found a stark difference between the ED utilization, where 22% of control families made 2 or more ED visits during that 12-month period compared to 10% of the intervention families. We also, at the end of the study, wanted to look at the intervention families who received the intervention, and we took a random sample of them, about 25% random sample of the intervention families, and did some more in-depth interviews to get some more information about how they perceived their care and what they thought about the intervention and each part of it. And so we talked first about the well visits. And the theme that came about from these interviews with the parents on well visits were that they thought that they were more comprehensive. They covered many items, and the wait time was used more efficiently. So that meaning that, and a lot of that was that wait time in the room. So parents were very aware of when they get put into the visit room and the door closes, how much time they're waiting. And so they liked the fact that while they were waiting, they were actually getting something done. This is a quote from one of the parents in the qualitative interviews. She said, "It's quicker now." She, meaning the parent coach, already knew what I wanted to talk about. And that's from that well visit plan or pre-visit tool I told you about. She knew what I wanted to talk about, what specific topics. It changed my experience for the better. Then we wanted to know a little bit about what their experience was in utilizing the parent coach. In terms of the parent coach, they really talked a lot about the rapport that she had with them. And I'll remind you, this was over a 12-month period where most kids were enrolled. The mean age of enrollment was 4.5 months. So most kids had about 3 visits with a parent coach. So over time, they really felt like they had a nice rapport built with her. And they felt like she used a family-centered approach. They also talked about the convenience and helpfulness of her availability between visits. So one thing I hadn't mentioned yet is that she had protected sort of Mondays, basically, where she did not see patients, and she was able to contact them to follow up on any community referrals she gave them the previous week or week before. They were able to contact her if maybe she gave them some recommendations on sleep training and things weren't quite working out. They could talk to her. So she had that time allotted where she would communicate with parents via a number of different ways, including phone. One of the parents that we interviewed said, "There was a time when my daughter was acting up. The parent coach downloaded a book for me and researched a facility where I could get more help or more information. It made me feel really special." And a lot of the things were, normal child behavior and development, but just things that probably parents in the audience have dealt with themselves and just need a little bit of help with. So what about the Well Visit Planner? That's that pre-visit tool that helped customize a visit to meet the parents' needs. So the parents, they thought the themes that came out from the interviews, it provided information. So if you remember, I told you that you could see the parents would have a list of the possible Bright Futures topics around anticipatory guidance for that visit, and they could click on them as well and actually read, get like a page synopsis of what to do about that issue or what the recommendations were for that particular topic. So a lot of parents utilized that and got information from the tool. And they felt like it prepared them for the visit. So they got a chance. I mean, these are busy Medicaid-focused clinics, waiting room. They had a chance to really plan what they wanted to talk about in their visit. So the other thing we noticed in the interviews was that computer literacy was a barrier. We used a kiosk, and we had like a little Chromebook, a small laptop it's pretty small, where parents could use the tool. But some parents, they just weren't able to complete it on their own. So they might get halfway through it, 3/4 way through it, and then need the parent coach to walk them through the rest. Another issue was that the kiosk was set up in the waiting room where they felt like they had to turn their back to either like their purse or their children. So there's a few logistical things that they mentioned there that need to be addressed. So one parent said, "I would do that well visit planner and I would see all the little options. I'd be like, yeah, I need to ask about that. I like the kiosk because that was more specific things. You could write comments if you needed to remember something." And then lastly, the text message service we haven't spent too much time talking about, but it's an automated text message service. The families, in the very beginning, they text in their child's birthday and the clinic that they go to. And the parents really felt like the text messages were coming directly from the clinic. So they thought it was a helpful source of new information and a reinforcement of some older information that they got at the visits. Some parents, so the frequency changed with the age of the child. For the young babies, they were weekly. As the child got older, sometimes they would spread out to every other week. So some parents said they would have liked more text messages. Some parents thought it was just right, but we didn't see any parents who thought they wanted fewer text messages. So getting that number just right without them forgetting that they were even part of the service is an important item too. One parent said, "It wasn't enough to where they bugged me," meaning the text messages, "but it was enough where I would remember. I think it was good like that." And this is kind of a key point because when you use a text message service for these for families who are changing their cell phone number frequently, if they're not frequent enough, they forget that they're a part of the service, and then by the time they change their cell phone number, they don't re-enroll because they just forgot about it. Obviously, if you give it too much, you might have families opting out because they don't want to spend all their text messages on the service. So in summary, this is as far as the parent-coach intervention goes, we found that the intervention families had better performance on the receipt of well child care services. So they were more likely to receive more anticipatory guidance topics and health education. They were more likely to get psychosocial screening done at their visits, and they were more likely to have a structured and developmental screen. They also reported better patient experiences of care, as far as the helpfulness of care and the family-centeredness of care, and they reported fewer ED visits over that 12-month period. So I'm going to go back to the original question, which is, does well child care have a future in pediatrics? And I think it does, but I think it's going to look a little bit different than we're used to, maybe a lot different. It's probably not sustainable the way that we have set up our well child care, and it's currently not really meeting the needs of the low-income population of children and families. So I do want to take a few minutes to acknowledge the partners and funders and my collaborators. The partners include the National Expert Panel that was very important to the development of the models, the practices and clinics that were involved, the developers of the Well Visit Planner, Healthy Text did the text messaging, and then our funders were NICHD, HRSA, and the UCLA Kaiser Center for Health Equity. And then I have a bunch of collaborators who are very important in this work that's been going on for a few years now. And I just want to point out that many of these are UCLA former medical students. I think all have moved on now to more things, residencies. And my collaborators from UCLA and RAND and mentors. So, thank you.